Alright, so in the last video, we looked at a lot of Kaplan stuff, right? We looked at what happens via Kaplan images and Kaplan descriptions of stuff, what happens after this first week, right? So just a tiny quick recap, and it's always nice to recap what you studied in your previous session when you start a new one. So yeah, this first early fetal development stuff we all saw already, and we got to the part where we finally do our implantation, right? Talked about all the genetics that were involved, and then this right here from weeks 1 to the end of week 3, right before you finally start organogenesis, we talked about everything in our last video up to actually week 4, where the neural tube and neuroectoderm and all that are going to start forming, right? So let me go back to that now. So yeah, last video we started it with the twinning stuff, right? And we talked about how instead of calling it separate, use share as the S word, right? Because I described in pretty logical detail that if you remember this as separate chorion amnion body, it can mess you up because day 4 to 8 is not a separate chorion, it's a shared chorion, right? So think of the first thing as share nothing, right? Share nothing, and then if you think of just scab, then it's share chorion amnion body, and those are the things that are shared within those respective days. Now that was one topic, and then of course the discussion of this and understanding where cleavage occurs. That discussion eventually led to twin transfusion syndrome, which was always going to be due to one placenta, right? And then whether or not one fetus has any symptoms of oligohydramnios or polyhydramnios. If there's a hydramnios issue, then that means that they're diamniotic, two different amnions where one amnion got compressed, right? If neither of the fetuses have symptoms of any kind of hydramnios, then there's one amniotic sac as well, right? And that would help you figure out what kind of pregnancy there must have been. Then we looked at the blood vessels. We understood, what's the fetal component, what's the mother's component, how it all looks, why it looks like that. And this was a nice time to go back and revise cardiovascular fetal blood supply, right? Where in the beginning of cardiovascular during embryology, you get to see how the blood supply is before the baby takes their first breath. We went through all these nice descriptions and images of the embryological development of the first few weeks, and ended at week 4, where you finally have your body folding and your 3 layers and everything, and then finished it up with figuring out what the indifferent gonads will become, right? Which is also a major mainstay of reproductive studies. Now we're up to the umbilical cord, right? So the umbilical cord, UWorld and every other QBank that has any images to it has at some point introduced an image like this one, right? It just looks like a face, right? You got your 2 eyes, the nose, and the mouth. The mouth, the one that's not circular, it's usually collapsed, is the umbilical vein, and you have to remember that there's only one vein, and the vein is actually the one that has, remember, it's red here, right? It's not blue. The umbilical vein is the one we saw before the Kaplan pages. Right here, umbilical vein is oxygen rich, right? The umbilical vein, the big red one in the center, is oxygen rich. The 2 umbilical arteries are oxygen poor. They're going to bring back deoxygenated blood. They're called arteries because they're leaving the heart of the baby, and they're going to bring deoxygenated blood back to the mother, right? Anything that leaves the heart is called an artery. Anything that comes to the heart is called a vein. So this vein is the one that's going to the baby's heart eventually, bringing blood to the body. So veins tend to have, a weak wall, right? They're not that strong. So the vein is usually the one that's collapsed like this. Arteries tend to have a pretty strong internal elastic lamina and all of that stuff. So they're pretty circular. They're round. They're like a nice tube. And of course, of importance is also you have your allantoic duct, right? And then all of this extra stuff is your Wharton jelly, okay? Now, of course, here we can see the same thing again as it's entering, right? And this is a breakdown of the blood supply inside the developing fetus, right? The developing fetus. So 2 umbilical arteries return deoxygenated blood from the fetal internal iliac arteries to the placenta. 1 umbilical vein supplies oxygenated blood from the placenta to the fetus, drains into the inferior vena cava, or inferior vena cava via the liver or via ductus venosus. Right now, here, of course, is, as I said, a great time to go back and revise cardiovascular embryology. So let's, throughout my videos in the full FA 2019 playlist, I've mentioned that studying medicine and studying from first aid comes with a lot of going back and revising things, right? And there are good opportunities to go back and revise things. Like when you're doing cardiovascular, most of the revision during cardiovascular, and cardiovascular is a very big chapter, most of the revision during cardiovascular should be for immunology, and pathology as you get through cardiovascular, because immuno and path are relatively smaller chapters. When you're done with cardio and you go into endocrine is all about glycolysis and gluconeogenesis, right? There's a big portion of that. That's when you start revising biochem, mainly metabolism, right? And revise all the sugar stuff. After endocrine, you go to GIT, and they talk about the urea cycle in endocrine a lot of times. Come back to metabolism, understand hyperammonemia. And you keep going, you're always going to see it. Like after GIT, you have HEMONC, and in HEMONC, G6PD is a big thing. So you go back to metabolism, look at your HMP shunt, G6PD deficiency, look at the different cycles of G6PD. There's a very systematic way to come back and revise things. Now, and I'm definitely going to I'm looking forward to making a video about that systematic pattern of studying correctly. So right now we're looking at fetal blood supply in reproductive embryo, and it's a great time to come back and look at the fetal circulation in cardiovascular. Very important to memorize it, right? So you can see there's 3 different shunts that allow the blood supply to be the way it is before the baby is born, before the baby takes his first breath. And this is definitely worth revising, so I want to come back and look at it. So blood initially comes in from the umbilical vein and goes to the inferior vena cava. You can see this red one, right? This is the highest oxygen saturation, right? You often get questions on UWorld and BME where the blood supply is highest, where it's lowest. The highest blood supply is in the umbilical vein. This then gives some blood into the liver, as you can see right here. And a lot of it now enters your inferior vena cava. So that's the second highest oxygen concentration, right? All this blood is now going into your inferior vena cava using the ductus venosus. Okay, so you can see the V's that I'm highlighting here, right? 1/3 will join the portal vein to supply the liver. 2/3 will bypass the liver via ductus venosus and go to IVC, which now finally brings blood into the right atrium. Now, from the right atrium, remember that during development, while you're still a fetus, your ventricles don't necessarily have a real purpose. So from the right atrium, blood just goes straight into the left atrium. Most directly and most importantly, your right ventricle doesn't have a real purpose, right? Because your lungs are not working, and right ventricle's job is usually to send stuff into the pulmonary artery and send blood to the lungs. Your right ventricle really doesn't have a purpose at all yet until the baby's born. So blood goes from the right atrium into the left atrium using your, where is it now, number... well, this one doesn't really necessarily have a memorization coloring, but yeah, foramen ovale, right, which is obviously very high yield. So blood goes from the right atrium to the left atrium using foramen ovale. From there now, right, you're able to send it to the rest of the body the typical way. Left atrium, left ventricle into the ascending aorta, and in your ascending aorta, all the blood gets sent mainly to the head, all right, and then some of it comes down here. So this color coding of where things are red are very critical. The ascending aorta, the inferior vena cava, and your umbilical vein are the places of very high oxygen concentration relative to the other places. Now, of course, some blood comes down the descending aorta too, right? But it's got pretty low oxygen concentration because the head and everything else, the muscles of the heart, all of those guys took up quite a bit of it. The liver took up a lot of it too. And of course, now to bring blood back to the placenta, all the deoxygenated stuff, you come down the descending aorta, right, and you just go ahead into your umbilical arteries. And you see those umbilical arteries eventually go back to becoming your umbilical artery too, and that's it. So this umbilical artery, you have to remember, comes off the internal iliac artery, right? Internal iliac artery. This little bit of anatomy shit always comes up. It's very possible to see it. And of course, a lot of this blood that went up in the ascending aorta will then later come back down using the superior vena cava. Right? So this deoxygenated blood that's coming down the superior vena cava also has to travel into the descending aorta somehow. And how does that happen? Well, all this low oxygen pressure blood that comes down the superior vena cava goes to the right atrium, into the right ventricle, enters the pulmonary artery, And there really aren't lungs to, do gas exchange, but you still have to bring blood to the lungs to supply them. So some of it goes into the pulmonary arteries and goes to the lungs. A lot of it uses your ductus arteriosus and goes back into the descending aorta, so you can send that deoxygenated blood back to the mother as well, right? And that's descending aorta, ductus arteriosus, DADA, right? So that color coding for memorizing that. Very important to understand that. And then, of course, the physiology of how things change after the baby takes the first breath. The first breath typically is taken within 10 seconds of birth, after mucus is aspirated from the infant's mouth and nose. The first breaths inflate the lungs to nearly full capacity and dramatically decrease lung pressure and resistance to blood flow, causing a major circulatory reconfiguration. Pulmonary alveoli open and alveolar capillaries fill with blood. Amniotic fluid in the lungs drains or is absorbed, and the lungs immediately take over the task of the placenta, which is exchanging carbon dioxide for oxygen by the process of respiration, right? Which is one of the many jobs of the placenta. So that's what they're kind of describing right here, right? What's happening. So if you didn't understand what's happening from here, then there's a little more detail in that, right? And that's your fetal circulation. So now we can come back to here. Right, so now you know your umbilical arteries and veins and where they come from. Now there's a couple other things that you get really easy, high-yield questions, and you don't want to mess them up. There's the Urachus and the Vitelline duct, right? And I've always thought of Urachus as urine, Vitelline as vitamins, which is feces, okay? So Urachus, in the third week, the yolk sac forms the allantois, which extends into the urogenital sinus. Allantois becomes the Urachus, a duct between the fetal bladder and the umbilicus. Failure of the Urachus to involute can lead to anomalies that may increase risk of infection and or malignancy like adenocarcinoma, if not treated. Obliterated Urachus is represented by the median umbilical ligament, right? And this was also discussed early in cardiovascular, or somewhere in GIT actually. Obliterated Urachus. The Urachus is median, right? Not medial. Median umbilical ligament, and it's a median umbilical ligament because there's only one, and it's in the middle. The medial stuff that you'll see also later on, there's two of them, and they're medial, but they're on both sides, okay? So median umbilical ligament after birth, which is covered by the median umbilical fold of the peritoneum. All right, so that's what you're seeing right here, the normal stuff. All right, now what can go wrong? You can have a patent Urachus, so it didn't get obliterated. If it doesn't get obliterated, remember Urachus is related to urine, right? So you're going to have urine coming out of the umbilicus, and that's going to be really problematic because the Urachus, or the belly button in general, is actually very prone to having bacterial colonization, and then of course all of that can back up into the bladder, and you can have infections, right? Infection. And they also mention malignancy, but most likely infection occurs for sure. Now the other thing is a urachal cyst, which you can actually palpate, right? So partial failure of the Urachus to obliterate, you get a fluid-filled cavity lined with the uroepithelium between the umbilicus and the bladder, just like they show here. Cysts can become infected and present as a painful mass below the umbilicus. And the last one is this thing, right, where the bladder just has a weird head sticking out. So that's a vesico-urachal diverticulum. Slight failure of the Urachus to obliterate, and you get an outpouching of the bladder, which, again, might be palpable, but generally speaking, it's going to be very asymptomatic. So this one is the least high-yield topic. Usually you're going to see one of these two in a question. All right, so Urachus, umbilical urine. Vitelline is umbilical vitamins, or feces. So what's up with the Vitelline duct? Well, the Vitelline duct, the 7th week, so remember Urachus was in the 3rd. Vitelline duct, in the 7th week, the obliteration of the Vitelline duct, or the Omphalmus enteric duct, same name, same thing, different name, will happen, and that thing connects the yolk sac to the midgut lumen, right? But now you don't need it, so by the 7th week, you can go ahead and obliterate it. And now it's supposed to look like this. Right, and we saw this kind of relation between the umbilicus and this part of the what might end up being like the jejunum or ileum, the small intestine basically. We saw this kind of connection in GIT, right, as the mechal diverticulum. So what are the two things you need to know? And these guys are almost more high yield than the Urachus stuff. So here, Vitelline duct, you can have a Vitelline fistula, which is a connection. So the Vitelline duct fails to close, and you get meconium discharge from the umbilicus. Right? And this is actually pretty common. You can see this happen. Right? Meconium discharge in the umbilicus. In fact, there are many humans who are completely normal development, and they still have some level of meconium discharge in their umbilicus. And it's a very common thing to find just a very weird stench in the umbilical area if you go ahead and finger it and actually smell it. And that's just something that happens. It's quite a weird thing in my opinion. I'm not sure why it's like that, but I guess this Vitelline fistula can often have smaller remnants that might be very asymptomatic. And even here they don't really tell you major symptoms besides the meconium discharge. So if the remainder of the Vitelline fistula is just really, 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 really tiny or skinny or small or whatever, you might still have some feces or fecal matter coming through. A mechodiverticulum, though, is a more problematic thing. This is a partial closure of the Vitelline duct with patent portion attached to the ileum, which is now going to make a true diverticulum, right? And that's what they're showing you right here. There's a true diverticulum. It's an outpouching of the whole thing, all three layers. May have heterotropic, gastric, and or pancreatic tissue, right? And this can lead to melena, hematochezia, and abdominal pain. And when we were in GIT and we looked at the mechodiverticulum, this was a very big topic, right? Finding the heterotopic gastric or pancreatic tissue, right? And that's what we're seeing here now. So let's take a look at these UWorld questions. There's one about the allantois, and this one's about the Vitelline duct. So UWorld, a 3-week-old boy with discharge from the umbilicus is brought to the clinic. His postnatal course was uncomplicated, with shriveling of the cord around 14 days of life. Vital signs are normal. Exam of the area reveals a small reducible umbilical hernia, minimal clear to straw-colored discharge from the umbilicus, which is obviously urine, and erythema around the area because he's at risk of infection. Lab results show high neutrophils and lymphocytes. He might already have infection. What is the most likely cause of the child's condition? This is a very straightforward question. It's a 3-week-old boy. Everything's fine. He just has some urine discharge from the umbilicus. It's because of a persistent allantois remnant. That allantoic remnant would be the urachus. He has a patent urachus. Right? And then the next one, 3-year-old boy is brought to the ED after he develops acute abdominal pain and vomiting. Image studies reveal a foreign body lodged within his intestine, causing a small bowel obstruction. Laparotomy is performed to remove the foreign body. During the procedure, an incidental abdominal cyst is discovered and removed. The cyst is connected by a fibrous band to the ileum and umbilicus. What condition is also caused by the same embryological defect responsible for this patient's abdominal cyst? So this fibrous band they're talking about should remind you of LAD bands. And when you look at all your answer choices, you should think of the Meckel's diverticulum. That would be the answer here. So they described that this patient has a Vitelline duct cyst. A Meckel's diverticulum is the most common Vitelline duct anomaly. Remember the rule of twos for Meckel's diverticulum: 2% of the population, 2 feet from the ileocecal valve, 2 inches length, and males are 2 times more likely to be affected. All right. So all kinds of ways to get basic questions on these things, but these are very basic topics. They're really not that hard to know. And of course, if you forgot any of it, go back and revise the mechodiverticulum from GIT. And nothing to revise for this guy. Yeah, so that's basically it. Now, the rest of this is just very annoying stuff that you have to know because you can get silly questions on it, right? Except for these last few pages. These are good. But this stuff, the aortic arch derivatives, right? The pharyngeal apparatus, the pharyngeal cleft derivatives, and the pharyngeal arch derivatives, right? These are very, and pharyngeal pouch derivatives, right? These are very much just hardcore embryology topics that really, there's no easy way to do it. There's no easy way to do it. It's just about looking at it over and over, revising it over and over until it sticks to your mind. So the first thing you have are your aortic arch derivatives, right? And these are the guys that are going to develop into the arterial system. So the good thing is that there's no nerves involved or anything other than arteries. We're just going to be talking about the blood supply. Now everything starts from, in this image, everything starts from third, fourth, and then the sixth, okay? But they have the first, second as well. So those not so bad to memorize. You do use the mnemonics they have here. Just, when you do practice questions, make sure you cheat, right? So if you find a question on this stuff, come back to the book, check if first you should read the question, then tell yourself, okay, maybe you think the answer is B or whatever, then you should go cheat, right? Go into first aid, open it up, look at it, and at the same time, you get to look at a couple other things. So the first is maximal, right? That's really easy. First arch is maximal, so the first aortic arch gives you part of the maxillary artery, which is actually a branch of the external carotid. The second is stapedial, right? So the second aortic arch gives you the stapedial artery, as well as the hyoid artery. The third, C is the third letter of the alphabet, so common carotid, right? Three. So again, you have to memorize it in this way. Unless you have a better way to do it, then by all means, obviously do it. But if you haven't thought of anything better, then definitely I liked it. It worked for me perfectly. Third is common carotid artery and the proximal part of the internal carotid artery. The fourth has different things on different sides because of the way the aorta is. On the left, it gives you the actual aortic arch. Okay, and that's pretty cool because that is where the arch is. On the right, it gives you the proximal part of the right subclavian artery. Right, you can see it's labeled right here. So basically, you're looking at both of the arches, right? So on the left, it's the actual aortic arch. On the right, this is the arch. It's your subclavian artery. And they say fourth arch for four limbs, which makes total sense because that's what the aorta does. It sends it to both hands and both legs. Sixth, proximal part of the pulmonary arteries, and on the left, ductus arteriosus. And that makes this pretty high yield, right? Because you do need to know ductus arteriosus very, very well. And of course, this is giving you your pulmonary arteries, which are also very important. So sixth arch, pulmonary and pulmonary to systemic shunt, which is the ductus arteriosus. It was a shunt. We just looked at it a couple minutes ago. Your ductus arteriosus was a shunt from the descending aorta to send blood into the descending aorta, right? Instead of sending everything to the lungs, send it to the descending aorta, the deoxygenated blood. So again, this is not so hard to memorize, and the good thing is it's just memorization. It's not that you have to learn anything crazy. It's really just memorization. Only goes up to the sixth arch, and everything's actually done 6 months postnatal. Right, so this is already going to be under work 6 months postnatal. The right recurrent laryngeal nerve loops around the subclavian artery, which you already need to know. We talked about that a lot when we talked about the thyroid. We talked about it a lot when we talked about neurology. On the other side, your left recurrent laryngeal nerve loops around the aortic arch distal to the ductus arteriosus. Right now, the ductus arteriosus stuff is pretty high yield, and there's actually a question here to help you remember that too, the fact that it is significant. A 4-year-old boy is being evaluated for failure to thrive, shortness of breath, and exercise intolerance. Cardiac exam shows bounding peripheral pulses and a palpable thrill over the left upper sternal border. On auscultation, a continuous murmur is best heard over the same region. If surgery is planned, the surgeon should intervene on a derivative of what embryologic structure. So that would be an embryologic structure of the sixth aortic arch. The patient most likely has a patent ductus arteriosus, an embryologic derivative of the sixth aortic arch that allows fetal blood to pass directly from the pulmonary artery to the proximal descending aorta, bypassing pulmonary circulation. And that's why the baby, the 4-year-old kid, is having issues with thriving and shortness of breath and exercise intolerance. He's not able to send enough blood, enough of the deoxygenated blood into the lungs. Right? And then you can't reoxygenate it again, and that's going to lead to weakness. Right? So the aortic arch derivatives are not so bad at all. This is the easiest part of the derivative shit that we have to know. Right? This is the easiest part. Now they start introducing your pharyngeal apparatus. So before you start looking at the cleft, arches, and pouches, you should know what they're talking about. Right? Really know the actual breakdown of where these things are, and then try to understand, because of that anatomy, what they're going to give you. So it's composed of the pharyngeal clefts, arches, and pouches. The clefts are derived from ectoderm. Pharyngeal arches are derived from mesoderm, and the pharyngeal pouches are derived from endoderm. Right? And we just saw in the beginning of embryology what each of these gives you. Right? What are the actual final adult derivatives of each of these layers? The pharyngeal clefts are also called pharyngeal grooves. Right? And pharyngeal arches are very high yield because they give you the neural crest stuff. Right? So bones and cartilage. And keep in mind that pharyngeal and branchial are the same thing. Right? So if it ever says branchial apparatus or branchial groove or branchial derivatives, etc., they're the same thing, right? So right here, pharyngeal arch derivatives, also called branchial arches, right, or branchial arches. So branchial stuff and pharyngeal stuff are the same thing. It's just an interchangeable name, right? And over here, you can see things are labeled, right? And they've got the color coding. So the clefts are the green things outside, right? And clefts are ectoderm. The arches are the pink stuff, and they're kind of on both sides here. So that's all mesoderm and neural crest. And then the pouches are the very purple stuff, right, inside here. Right, so those are your pouches, and the pouches are all endoderm, which is why they're inside. Here in this image on the left, we're looking at the pouches. So pouch 1, 2, 3, 4, 5, and then your esophagus. Here in this thing, you have your grooves, right? 2, 3, and 4. Brachial arch 1 and brachial arch 2. It's just a weird image that was online, so I put it here because the point of this image was to get you to understand that all of these things can present in really weird ways. And I don't think I've ever seen a picture where you had to label things from a picture like this. But if you do get it, right, it's pretty nice to remember that if you remember the cap thing, outside to inside, then you can always remember what you're looking at, right? And your the clefts that they're showing you here are almost never really visible that nicely on this kind of stuff. Okay, so now what do you need to know? Well, clefts are the easiest of these three. Of your pharyngeal apparatus, the clefts are the easiest to remember. Right? Pharyngeal cleft derivatives are also called pharyngeal groove derivatives, right? They are grooves outside. So cap or gap, either one is okay. Yeah, branchial equals pharyngeal. Yeah, it's definitely something that was pretty confusing to me the first time I heard of it. The first time I was like, yo, so wait, we have to know pharyngeal stuff and branchial stuff? Like, it was too much. But then when I actually started studying and figuring out what these things are, I found out they're the same shit. So the first cleft develops into the external auditory meatus, right? The second through fourth clefts form temporary cervical sinuses, and that's what this image is kind of showing you. Cervical sinuses like this, okay? These are your clefts, but you almost never really see them. Like, this is a nice image made to show you them, but you don't really often see your clefts because they're just temporary and they disappear. Right, so second through fourth clefts form temporary cervical sinuses which are obliterated by proliferation of the second arch mesenchyme. Right, you can see how the second arch is starting to become really big, and this sinus is going to just disappear. If the sinus does not disappear, then you can get a persistent cervical sinus, which is a pharyngeal cleft cyst within the lateral neck, anterior to the sternocleidomastoid muscle. And this was actually discussed in endocrine embryology. Let's go back and take a look at it. When we talk about the thyroid, right here. Right, so you can see they talk about a thyroglossal duct cyst presents as an anterior midline neck mass that moves with swallowing, just like the thyroid, or protrusion of the tongue, versus persistent cervical sinus, which leads to a pharyngeal cleft cyst in the lateral neck. Right, we can see some more pictures here that are showing you. You see the cervical sinus here. If it doesn't go away, it might give you a cyst on the lateral neck, and it doesn't move with swallowing or anything. Okay, so that's going to be a big differential between the two guys. So again, the cleft is one of the easiest things, even comparing to the aortic arches. The easiest thing, all you have to remember is the first cleft is your external auditory meatus. And I just think of the fact that you should always listen before talking, right? Hear a person out before talking, or before looking at them at a certain way, or judging them, etc., etc. You'll have, for the persisting cervical sinus, you'll have a child with a painless lump on the side of the neck that does not move when he swallows. In comparison, ectopic thyroid tissue will generally move with swallowing, right? Or like the thyroglossal duct cyst is what I'm really talking about. So let me actually change that to thyroglossal duct cyst. Because not just any ectopic thyroid tissue, all right? But this is all that's going to be for. Now here's where it starts getting a lot more complex, right? So now we have a pharyngeal arches, right? We have your first pharyngeal arch, second, third, fourth to sixth, and a couple notes and images to help you understand why you need to know this stuff, right? And where it all goes. Now this color-coded picture does a really nice job helping you memorize where the arches go, what they give you. Right, so all the green stuff you're seeing. First of all, this picture on the top. So let me zoom in. Or can I make it bigger? Let me just make it bigger. Yeah. Okay. So first of all, right here in the developing fetus, this is how your arches are, initially like. Right. So they're all color coded 1, 2, 3, and then 4 and 6. The fifth one is just a trichostroid. It doesn't do shit. All right. So these are your arches, and they're gonna give you a bunch of stuff as the baby starts making shape. Right. And you can see here on the green stuff, right, arch 1, you have your malleus, your incus in the ear, okay, your maxilla and mandible, so that's your mouth, right, and then everything else now, so you can see the pink stuff, your arch 2, gives you another thing for the ear, the stapes bone, and then the styloid process, right, so stapes and styloid, your two S's, and the lesser horn of the hyoid right here. Okay, the greater horn of hyoid is purple. That's the only thing over here from arch 3, right? These are your bones. Up here, these are muscles. And then the last few bones, arch 4 and 6, are for the cricoid and thyroid cartilages, right? The muscles are a whole different thing, but very similar kind of use. So now there's more facial stuff from arch 2. A lot of your facial muscles, oculus or orbicularis, the ones around your lips, your facial expression, all of that right here. A little thing in the back of the head, and these guys that kind of help you move your muscles right there in your temple areas. But the bigger muscles you're seeing, the green ones, right, those are arch 1. Your muscles of mastication, right? Arch 1, the masseter, temporalis, medial and lateral pterygoids, these are all arch 1. Arch 2 is your muscles of facial expression. Arch 3 is your swallowing muscles, kind of, sort of, stylopharyngeus. Right? And then arch 4 and 6, pharyngeal and laryngeal muscles, which are also for swallowing. Stylopharyngeus is not exactly swallowing, but the 4 and 6, they are. Now, it's very important to memorize them based off of what they're for, because you're going to have to know associated nerves as well. Alright, so here's how you memorize these guys. And again, you should do your best to memorize all of it the first time you study it seriously. And then whenever you're doing questions, you can come back and revisit it and study it a little more to seal out anything you might have missed. So let's look at the first one. Your first pharyngeal arch or branchial arch gives you all these things that are related to cranial nerve V3, right? So first of all, the nerves and arches are actually numerically related in a way. So 1 goes to 5, 2 goes to 7, 3 goes to 9, and then 4 through 6 are for 10. Right, so you have your 5, 7, 9 thing that's happening. The odd numbers, very important to catch that. Not so hard at all. As a cranial nerve V3 was for chewing, right? That's what the nerve generally helps with. Cranial nerve 5.3 or V3 is for maxilla, mastication, and music, okay? V3 is also the nerve responsible for general sensation of the anterior 2/3 of the tongue. Alright, so now let's look at all the cartilaginous stuff you get. So you get your maxillary process, the maxilla and zygomatic bone. You get your mandibular process. We got both the upper and the lower jaw from your first pharyngeal arch, right? Mecocartilage, mandible, malleus, and incus, sphenomandibular ligament. The malleus and incus are the bones that are the tiny bones of the ear. The stapes is the only one that didn't come from the first one. It came from the second one. What muscles do you get from the first pharyngeal arch? Well, you get all your muscles of mastication, right? Mastication, the masseter, the medial and lateral pterygoids, the mylohyoid, anterior belly of the digastric, your tensor tympani in the ear, right? Anterior 2/3 of the tongue, which also makes sense because of V3, and tensor veli palatini. You do need to remember all of them, not just the ones that are highlighted with the M's or whatever. You have to know all of them. You have to know all of them because you get any kind of weird question. You can get a question about tensor veli palatini, and you have to remember it came from the first pharyngeal arch. So that's pretty annoying. But do note that a lot of shit is coming from the first pharyngeal arch, right? And the second pharyngeal arch is a little easier, right? You just have your S things, stapes, styloid, stylohyoid, and then that'll remind you of the hyoid too, right? Styloid and hyoid, as well as stylohyoid, all right, all three of them. And the stapes was the only bone left in the ear. And what does it give you? Well, it's related to facial nerve, cranial nerve 7. Right, cranial nerve 7, smiles, stapes, and styles for stylohyoid. Right, these are just memorization things I made up. So cranial nerve 7, you get your stapedius, stylohyoid, platysma, and the posterior belly of your digastric. Right, anterior belly was here, right here, anterior belly of the digastric muscle. Then you have your posterior belly of digastric muscle. Okay. Now, there are diseases or syndromes related to the first and second pharyngeal arches and things going wrong. You have your Pierre-Robin sequence and Treacher-Collins syndrome. I'm going to come back to those. Let's just finish this up first. Third pharyngeal arch is the easiest one. This is the one that's related to cranial nerve 9. Right? So 9 for stylopharyngeus, swallow stylishly. Okay? Cranial nerve 9, your glossopharyngeus, but they call it stylopharyngeus. Okay? Why? Because it gives you your stylopharyngeus, right? And think of stylopharyngeus innervated by glossopharyngeal nerve, stylopharyngeus, right? It gives you the stylopharyngeus. That's the only muscle you get here. And the greater horn of the hyoid as far as bone and cartilage are involved. Very easy one to remember. There's really nothing, there's no list here per se. The last thing are your 4 through 6, which are more so for the throat, not for the face or anything like that. The ear, none of that. It's just the throat. So you have your arytenoids, cricoid, corniculate, cuneiform, some of those bones that you might know of around your thyroid. So they have very nice leaf type structures and stuff. And thyroid cartilage, right? Now, what is the difference between them? Well, the fourth arch gives you most pharyngeal constrictors, right? Levator, palatini, cricothyroid, etc. The sixth arch gives you all your intrinsic muscles of the larynx except for cricothyroid, which came from the fourth. So you see that little exception can give you a lot of space for questions, right? And you have to be ready for that. The cricothyroid muscle is responsible for contraction of the vocal cords, which causes the voice to become high-pitched in laryngeal carcinoma, right? Or even if you have laryngeal infection with HPV causing warts in the larynx. Remember, we've seen questions on that stuff too. That's all related to cricothyroid muscles being involved. Arches 3 and 4 form the posterior one-third of the tongue. Arch 5 makes no major development contributions. Right, and remember, arch 3 and 4 do give to the posterior one-third of the tongue because the posterior one-third of the tongue was innervated by cranial nerve 7 and 9, both for different things. Right, so let's just do a quick revisit of the tongue because obviously development of the tongue was pretty high yield. Right, so that's in, where did we see that? I think it's neuro. Yeah, there you go. Okay, not GIT. Right, so you can see a posterior is arches 3 and 4. And remember the nerves that are related to it. Arch 3 is related to cranial nerve 7. Arch 4 was related to cranial nerve 9. Right? So you can see here in the back, for the posterior, you have your, what is this? Cranial nerve, yeah, right here, right? Taste. Cranial nerve 9 for the taste. Cranial nerve 9 for the sensation. Okay? The front is arches 1 and 7. What am I saying? Right. Arch 1 was for cranial nerve 5, right? Arch 1 was cranial nerve 5. Arch 2 was cranial nerve 7. Excuse me. Arches 1 and 2 are for cranial nerves 5 and 7. And arches 1 and 2 give to the anterior, bigger portion of the tongue. And that's why you see both nerves here. Both nerves are here. Right? From 1, you're getting cranial nerve 5, which is going to have the lingual nerve and it's going to help with sensation. From arch 2, you get cranial nerve 7, and the chordotympany branch of that is actually going to be there for taste in the anterior 2/3 of the tongue. The posterior 1/3 of the tongue comes from arches 3 and 4, which are actually related to 9 and 10, right? And that's why you have all of that back here. 9 is a really big number, so the 9 is able to take care of both taste and sensation in the back of the tongue. The far back of the tongue is all by cranial nerve 10, taste and sensation. It's very important to have your tongue development stuff down too, because again, it's just an easy memorization question. You don't want to mess that up. Very easy memorization question. The more times you revisit it, of course, you'll get better at it. But you want to make sure that you're ready for that. So again, right here, right, arches 3 and 4 give you the posterior 1/3 of the tongue. So the third one is cranial nerve 9. Fourth is for cranial nerve 10. And those are all there as we just saw in the tongue picture. The first two guys, arch 1 and 2, they give the anterior 2/3 of the tongue. So you can see V3 and 7 in the anterior 2/3 of the tongue. Right? They have function there. Now, other than that, you have this stuff here, little notes of the nerves. The fourth arch does give you cranial nerve 10, but it's also mostly for the superior laryngeal branch. Right? The sixth arch gives you the recurrent and inferior laryngeal branch. Right? You can get silly questions on those guys too because vagus nerve is very high yield. But again, this is definitely a lot harder than the cleft was. The cleft is just one thing. First cleft gives you your external auditory meatus and you're done. It's also much harder than your aortic arches were because these were really easy to memorize with the tools over here. Thing is, it takes time. So you can actually devote an entire day to get just get these arch and all these derivatives down, memorize them correctly, and then of course look at more pictures like this one here. You can print this out for yourself. And really understand the two diseases we're looking at right here, right? So what are these diseases? Pierre-Robin sequence, the most prominent feature is the micrognathia, and then the most fatal symptom is the airway obstruction, and you can die from not breathing correctly. Right, so you can see that in this picture right here, as well as this kid, right? Micrognathia, a small jaw with a receding chin. Right, so the chin is kind of tucked in, right? And then because the chin is tucked in, you can imagine other things are tucked in, and that causes airway obstruction. right? Tongue that is large compared to the jaw, resulting in airway obstruction, right? But also the chin being tucked in didn't really give the tongue much space either. So it's not always just because the tongue is large, but there just isn't as much space as there would be had this chin been further out to the right level. Right, so micronatia. So these kids can actually end up dying because they couldn't breathe correctly, right? Breathing is not supposed to take extra effort in this area. Treacher Collins syndrome, you usually see these pictures at any age, and you can see adults as well. Autosomal dominant neural crest dysfunction, which makes this very high yield because there's a neural crest dysfunction, leading to craniofacial abnormalities, so you get zygomatic bone and mandibular hypoplasia, hearing loss, and airway compromise. Right? And they can just present very differently, but they're able to function like normal people just fine. Okay, they just didn't physically develop correctly, and it affects their facial structure very much. But they are not mentally retarded or anything like that. They function just fine in society. Right? You just get physical abnormalities, craniofacial abnormalities, but no brain abnormalities. Alright, so that's really it for that stuff. The last thing are your pharyngeal pouches, right? And based off of the cap mnemonic, remember, right, your pouches are endoderm, outside to inside. A cap that you wear on your hat covers you from outside to inside. So pouches are all endoderm. So what's happening here? So you look at your first pharyngeal pouch, middle ear cavity, eustachian tube, and mastoid air cells. These are the things you get from the first pharyngeal pouch. How would you remember that? Well, let's look at all of them and then we'll come back to it. But the main thing is, they have this mnemonic thing, ear tonsils bottom to top, but it didn't really ever work for me that well. But just like the first cleft gives you your external auditory meatus, it was all about listening first. The first pouch also does the same thing, ear stuff, right? So the cleft gave you the external because the cleft was the C of cap. That was your ectodermal stuff. This is endodermal, so it's going to be deeper in, right? So middle ear cavity all the way to mastoid air cells. First pouch contributes to the endoderm line structures of the ear. Second pharyngeal pouch, no big deal. Epithelial lining of the palatine tonsil, right? Now, third and fourth pouches are very high yield. These guys show up all the time because of their relations to the parathyroid. And this image here is kind of showing you the same stuff we looked at earlier, right? So you remember your cervical sinus, right? Your second arch collapsing onto the cervical sinus. The sinus had the second, third, and fourth grooves in here. These are all just going to disappear. The first cleft we already talked about, right? First cleft gave you your external auditory meatus. So right here, this yellow stuff in here, right? Your first pouch is going to give you the middle ear cavity and everything lining the endoderm lined structures of the ear. Okay, that's the first pouch right there. Second arch is huge, that's this guy, and second arch had many derivatives. Right, your second pouch though, not much. Third and fourth pouches are mostly related to each other because of their inferior parathyroid and superior parathyroid stuff. Even though the third pouch is above the fourth pouch, right, it doesn't stay that way. And if I zoom into this picture here, and you need to find pictures like this and talk about everything that comes from these things without looking at the book. That's when you know you've memorized it. Right? So you should be able to look at something in this picture and all these things that are labeled 1, 2, 3, 4, and then tell me what the main high yield structures that come out of them are. Right? That's when you know you're ready. So anyway, if you look here, right, and we're talking about the third and fourth pharyngeal pouch. So pharyngeal pouches are labeled here, right? So 3 and 4, right? You can see the third and the fourth, they both have two things to it. They have the yellow stuff, and they have the red, and this one has the blue. Right? These are your third and fourth pouches. They have two segments to them, each one on both sides. In the image to the right, you can see the third pouch has yellow and red parts for the dorsal and ventral wings. The same is true for the fourth pouch, which has a yellow and blue part for the dorsal and ventral wings. The dorsal ones are the ones that are yellow in these images. The yellow dorsal parts give the parathyroids, and it's important to remember them. Now, what's cool is that as this develops, the third one ends up falling below the fourth one. Okay? And especially the dorsal part. The third one ends up falling below the fourth one. So because of that, right, you see that the third one gives you your inferior parathyroids. The fourth one gives you your superior parathyroids, even though the fourth one is below the third one initially. Right? So that's what they're telling you here. Third pouch contributes to 3 structures: your thymus, left and right inferior parathyroids. The third pouch structure ends up below the fourth pouch structures. Right? This one, the third pouch, also gives you a thymus, which is obviously also very high yield, whereas the fourth one gives you your parafollicular C cells, which remember are of endodermal origin. Okay, endodermal origin. That was a weird topic on first aid for the longest time because they had a mistake or a misunderstanding where they mentioned that C cells were neurocrest derivatives. So again, this is just stuff that takes repetition, but also it's not just passive studying where you just reiterate things and look at it over and over. You have to do it actively too, like kind of like doing questions. Print out a picture like this, which shows you your first cleft, second, third, and fourth cleft inside the cervical sinus, and this is all going to get obliterated because your second arch here is developing very, very rapidly, and it collapses onto it, right? You can see all your arches, the first, second, well, these Roman numbers are for actually the pouches, but you can see your clefts too. This is the first arch here, the blue area. This is your second arch, right? And then you're going to have the rest of them. The Roman numbers here are actually related to, actually it is, yeah, the Roman numbers here are your arches. These are your arches, yeah, first, second, third, and fourth arches, yeah. And then on the right side, the numbers 1, 2, 3, and 4 are pointing deeper in to the actual pouches, right? So this is your first pouch, which gives you the inner ear stuff, mastoid ear cells, middle ear cavity, all the way to inner ear stuff. Second pouch, which only gives you the tonsil stuff. The third and fourth pouches, which are for the parathyroids, thymus, and C cells. Right? You really need to be able to print out a picture like this and just talk about everything that's coming out of it without needing the book in front of you. Okay? And that's when you know you've memorized it well enough to go kick ass on your test. Okay. So the last thing I want to show you here is this other image I found. You can find all these pictures very easily online. This image is just like a table that you can rewrite for yourself too. And it does a pretty decent job, telling you everything that comes from everything. Okay. And it's mostly a summary stuff, so I mean, if you don't really care for the table, don't use it. But if you do care, or if you do want to reiterate the table for yourself and make it more complete by adding anything they're missing, by all means go for it, right? It's a nice way to have the information visualized, different from how the book shows you. Okay, so that's it for now. I'm gonna stop here. In the next video, I think, yeah, the next video is gonna be the last video for reproductive embryology, and then we'll finally be going into reproductive anatomy. Thank you very much for joining. Keep studying, guys, and I'll catch you guys tomorrow.